Hi, this is a presentation for medical students, all about bleeding from the lower GI tract. I will cover history, examinations, and differentials. So this is a picture of the GI tract. When we talk about the lower GI tract, is anything below the duodenum, so the large intestine, small intestine, the rectum, and the anus. And the upper GI is the duodenum, the stomach, and the esophagus. Rectal bleeding could be overt or occult. Occult meaning is invisible to the clinician, and overt is visible. So the bright red type of bleeding, this can occur in the left side of the colon or the rectum, but it can also occur with large bleeds in the upper GI tract. Maroon type of bleedings occur from the right side of the colon. Melena is black tarry stools caused by digestion of blood, usually from the upper tract, but it can also originate from the colon and small bowels. If you notice clots in the rectum, then that's probably from the lower GI tract. Other features you may notice is anemia, which is a reduced blood count, and this is usually due to a chronic condition such as a slow-growing cancer or a large acute blood loss, which is usually an emergency, and we should think about shock, so tachycardia, hypertension, tachypnea, reduced urine output, delayed capillary refill, and altered mental state. And some other features you may notice is abdominal pain, rectal pain, nausea and vomiting, dizziness and lightheadedness, weight loss, flatulence, mucus and fatty stools, um, and then distension, which you can see here, and cachexia, which you may see in cancer, jaundice and liver disease, and then fatty stools here again, and aphthous ulcers, which you may see in things like inflammatory bowel disease. So for history taking, you would start with an open-ended question. So how may I help you today? And they may say, I have been passing blood, doctor. And then you'd move on to history presenting complaints. So you'd want to ask about the nature of bleeding, the duration, the frequency, the color. So is it black, red, maroon? And is it related to stools and defecation? And then you want to ask about pain, and you may have heard about Socrates. So Socrates stands for sight. So where is the pain? Is it in the central tummy? Is it all over the tummy? Is it rectal pain? And also about onset. Did it start gradually or suddenly? And when did it start? And also character. What sort of pain is it? Is it sharp, dull, constant, intermittent? And also radiation. Does it move anywhere? And how has the pain changed over time? Is it getting better or worse, or is it the same? Any exacerbating factors? What makes it better or worse? And also the severity. And how I like to ask this is 10 being the worst pain you've ever had. How would you rate it on a scale of 1 to 10? You could also ask about nausea and vomiting. Is there mucus in the stools? Has there been weight loss, any fatigue, any fever? Diarrhea and constipation is very important to know. Any dizziness, lightheadedness. And then, as well as asking about stools, you'd want to ask about urination, recent travel, and contaminated foods and water, diet appetite, and fluid intake. And also, the red flags are very important. So, would be alarm bells will be ringing if it's someone over 50, and if there's unexplained bleeding, rectal bleeding, if there's abdominal or rectal mass, if there's a change in bowel habit, especially in the elderly, and any unexplained weight loss and unexplained anemia. And then you'd ask about the past medical history, which is very important, any surgical history. Medication history is very important because certain medications can cause bleeding as well. Family history of bowel cancer or inflammatory bowel disease, and social history would include smoking, alcohol, and other drugs. And then you can finish off by saying if there's anything else you'd like to tell me. So to start off with the examination, you'd want to do vital signs, and you can see on this lovely table here, someone who's lost a lot of blood, their heart rate's up, their breathing rate is up, their blood pressure is reduced, and the urine output's reduced. Then you move on to the examination of the abdomen. You'd wash your hands, wear appropriate PPE, introduce yourself, explain, and gain consent. And I'd like to go for the look, feel, listen approach. So you start off by looking. How do they look? Do they look pale? Do they look jaundiced? Do they have ascites? Do they have a distended tummy? Do they have a liver flap or spider nevi? Or do they have clubbing? And any hernias? Can you see any hernias? Or do you see any medical adjuncts such as a stoma bag? Or any scars from previous surgeries. Next, you'd like to feel for the abdomen, and firstly, you will start by feeling lightly on all the 9 quadrants, and then deeper to feel for any masses, and then you can feel the abdominal aorta. And you shouldn't make your hands spread apart too much. If it does, then it could mean that they've got an aneurysm. And you'd also want to feel for the liver for any hepatomegaly, and also the spleen for any splenomegaly. If you can feel the spleen under the rib, that's almost always abnormal. And the liver, you should be able to feel maybe 1 centimeter below the rib when you ask them to take a deep breath, but no more. And this is how you feel for the kidneys. And this is how you can percuss also. And the way you percuss is from down and go up towards the liver, and you can see that the liver should feel dull. And also check for pitting edema on the legs and the abdomen. Next, you'd like to listen to the abdomen, and that will be 2 inches above the umbilicus, and you should be able to hear bowel sounds, and also the arteries, and also the heart sounds as well. If you hear a high-pitched tinkling sound, this could mean obstruction. If you don't hear any sounds at all, it could be peritonitis, but give it 2 minutes if you can't hear anything at first. You may also hear bruits, which is a whooshing sound, which is a rhythmic sound. This could mean an abnormality in the aorta or the renal arteries. At this point, it's probably a good idea to listen to the heart and the chest if appropriate. Now, for any PR bleeding, you should do a PR exam. So you start off by appropriately PPE'd, explain the examination, consent, and offer a chaperone. In terms of what position the patient should be in, it really depends where you are. In the UK, we have the left lateral position. I like to go for the look and feel approach. So now that you've undressed them appropriately and you've gained consent, you'd like to have a look. So you can see here, there's some picture of a hemorrhoid. There's another picture of a hemorrhoid here. This is an internal one, external one. There's a picture of a fissure here and skin tags. You can also ask them to cough to see if there's any rectal prolapse or any internal hemorrhoids that might show up. Now that you've had a look, now it's time to feel. Get some gel on your finger, warn the patient, insert your finger gently into the canal, and then in men you can also feel the prostate, which is anterior. It should feel nice and smooth, not lumpy, size of a walnut. And then go ahead and spin your finger 360 to feel for any lumps, any bumps, any pain, and also feel for any stools. Hard stools could mean constipation. And then go ahead and ask the patient to bear down on your finger, which checks for anal tone. A lack of anal tone could mean a spinal pathology or inflammatory bowel disease. Withdraw your finger and have a look at the glove, see if there's any blood. And this is the image of where the prostate is in men. Now there are quite a few differentials actually for rectal bleeding, but let's just start with this lovely image here. We'll focus on the lower GI tract, and let's start with ischemic bowel disease. So this means reduced flow to the intestine, and there are many reasons for this. One of them is shock. The next thing is interception, but this is more pediatric, so I wouldn't focus on this. The next thing we can look at is angiodysplasia, which is abnormal blood vessels. We're not sure why these occur, but these are fragile, they can break and they can bleed easily. And here you can see a colonic cancer and a rectal sigmoid cancer, which can also cause, as well as blood loss, it can cause weight loss, fatigue, fevers, and change in bowel habits. Okay. And then more commonly what I see in my practice is hemorrhoids and fissures, and both of them are usually caused by poor diet, constipation, straining, lack of fluid. And hemorrhoids are basically the vascular cushions that we naturally have in the lining of our rectum. They get pushed out into the lumen, and these can get irritated and can bleed. With the anal fissures, same thing. With the constipation and the patients is strained, they can have these small tears which are very painful and also can bleed. Diverticulosis are normally we see in the older population. What happens is there's outpouching in the weak points of the bowels, and it causes outpouching, which can get irritated, inflamed, and can also bleed. Inflammatory bowel disease. Now this includes ulcerative colitis and Crohn's. Crohn's can affect anywhere along the way of the GI tract, even the esophagus and the mouth. The ulcerative colitis usually only affects the colon and the rectum, as well as the anus. And of course, this can cause bleeding, weight loss, fevers, change in bowel habits. Okay. And a quick slide here of the things I've just talked about in a bit more detail. These are the references.